A very good morning. It's a great pleasure to be here today. I'd like to thank the organizers, in particular Fraser and Dennis, for the opportunity of being a discussant at this poster spotlight session. These are my conflicts of interest. And in the next 20 minutes, we'll be discussing excellent studies that focused on genomic signatures in breast cancer. I think we're all now aware of the 5 different first-generation prognostic signatures that are commercially available: MammaPrint, Oncotype, PAM50-ROR, EndoPredict, and Breast Cancer Index. All of them are supported by Level 1A or Level 1B evidence, in particular for the prognostic information that they provide related to early risk of relapse. There are many questions that remain about the use of these signatures in complex clinical scenarios, in particular for late relapses, extended endocrine therapy use, and patients with specific subtypes. And in this session, we're up for a treat, actually, because we have 5 excellent posters that relate to these signatures. Poster 1, that will be presented by Dr. Olga Kanter, focuses on Oncotype DX. Posters 3, presented by Dr. Ma, and poster 5 by Dr. Lundgren, focus on PAM50 subtyping and risk of recurrence, ROR. Poster 6 focuses on the SET23 index. That's slightly different. It's a combinatorial index, and also Oncotype DX results. And poster 9 focuses on the breast cancer index, but the 2 different components, the molecular grade index and the HOXB13 IL-7BR ratios. So the first poster focuses on the expansion of the downstaging criteria of AJCC on the basis of Oncotype DX recurrence scores for patients with T1-2 node negative enrolled in the TAILOR-RX trial. And here we have to remember that AJCC in its 8th edition included the pathologic prognostic staging, or PPS, that incorporates both anatomic and biologic factors. Based on a previous analysis of the TAILOR-RX trial, it has become apparent that patients who have an Oncotype recurrence score less than 11 can be downstaged to PPS 1A. And a retrospective analysis carried out by the investigators supported the notion that perhaps a recurrence score less than 18 would also allow for a downstaging to PPS 1A. So the purpose of the study presented here was to define whether the recurrence score less than 18 would justify the downstaging of patients to PPS 1A through an analysis of the materials from the TAILOR-RX trial. So in this study, they included 9,535 patients with tumors that were T1 or 2 node negative, hormone receptor positive, HER2 negative. They performed a recurrence-free survival analysis, and for the purpose of the TAILOR-RX, the PPS classification, the AJCC PPS classification included in stage 1A all T1 and 0 cases that were grades 1 to 3 or in any recurrence score, or T2 node negative grades 1 to 3 and recurrence score less than 11, or grades 1 to 2 recurrence score greater than or equal to 11. And by performing this analysis, the authors made some very important observations. If you look here on the left side of this slide, all patients included in this analysis, regardless of treatment, they observed here in the blue curve that are the patients that were classified as PPS 1A using that definition, and then the patients that were not PPS 1A but had a recurrence score less than 18 in green had a curve that was not statistically dissimilar from that of the PPS 1A, whereas patients that had a recurrence score greater than 18 had a significantly worse outcome. And this was valid both for the endocrine therapy arm or the chemoendocrine therapy arm. So the conclusion of this part is that in this unplanned analysis of the TAILOR-X trial, patients with T1/2 node negative, who were hormone receptor positive, HER2 negative, and had a recurrence score less than 18, had an outcome not statistically different from those patients that were classified as PPS1A. And that consideration should be given in terms of expanding the criteria of PPS1A to perhaps including those patients with recurrence score less than 18, not only those with less than 11. This study was an unplanned analysis, and there are many questions that still need to be addressed. For instance, if this would be valid for younger patients, premenopausal patients, and patients with special histologic types of breast cancer. In the second poster, the authors investigated PAM50 subtyping in ROR for the prediction of endocrine therapy sensitivity and pathologic complete response to chemotherapy in postmenopausal patients with estrogen receptor positive breast cancers included in the alternate trial. And the premise of this study is really appealing, in that neoadjuvant endocrine therapy gives us a unique opportunity to derive novel biological insights and devise new biomarkers for endocrine therapy sensitivity and resistance. As a matter of fact, a Ki67 greater than 10% at weeks 2 to 4 on neoadjuvant endocrine therapy is a biomarker of intrinsic endocrine therapy resistance. Conversely, an PCR or an mPAPI-0 at surgery following neoadjuvant endocrine therapy are biomarkers of endocrine therapy sensitivity. The PAM50 assay, both the subtyping and the ROR, these assays offer prognostic information for patients with ER-positive, HER2-negative breast cancers, as well as potential predictive information for pathologic complete response following neoadjuvant chemotherapy. So in this study, the authors sought to use PAM50, both the subtyping and the ROR, and apply it to pre-therapy biopsies from patients included in the alternate trial, which is a phase 3 study that randomized patients with ER-rich, meaning high levels of ER expression, into 3 neoadjuvant endocrine therapy arms. If the patients had a high Ki67, they could be triaged to neoadjuvant chemotherapy. And they used then the PAM50 subtyping in ROR derived from mRNA sequencing and correlated it with a high on neoadjuvant endocrine therapy Ki67 at weeks 4 to 12, which would be a biomarker of resistance to endocrine therapy, or mPAPI-0 or PCR at surgery post-neoadjuvant endocrine therapy as a biomarker for sensitivity to endocrine therapy. The results of this excellent study are summarized on this slide, where we have here the rates of Ki67 greater than 10% at weeks 4 or 12, which is a marker of resistance to endocrine therapy, or the rates of mPAPI-0 or PCR at surgery post-neoadjuvant endocrine therapy that are a marker of endocrine therapy sensitivity. And as you can see here, luminal A showed the lowest rates of resistance and the highest rate of sensitivity to neoadjuvant endocrine therapy. Luminal B had intermediate rates, but the non-luminal breast cancers, which accounted for 7.2% of all cases, had the highest rate of Ki67 greater than 10%, so resistance to endocrine therapy, and the lowest rate of mPAPI-0 or pathologic complete response post-neoadjuvant endocrine therapy. In addition, the ROR results actually correlated with the Ki67 greater than 10%, with the high ROR showing a high rate of Ki67 greater than 10% and a low rate of mPAPI-0 or PCR. So in conclusion, this study demonstrated that PAM50 non-luminal subtypes were observed in 7.2% of the alternate trial patient population, despite the fact that these patients had high levels of ER expression by immunohistochemistry, that Ki67 greater than 10% at weeks 4 or 12 on neoadjuvant endocrine therapy, or mPEP-0 or PCR post neoadjuvant endocrine therapy, varied according to PUM50 subtypes and ROR, that PUM50 non-luminal subtypes, or those that have a high ROR, had markers of resistance to endocrine therapy. I did not have time to show you here, but for the patients triaged to neoadjuvant chemotherapy on the basis of a high Ki67, they observed that there was no pathologic complete response in luminal A breast cancers, and the highest rate was observed in the non-luminal subtypes. Taken together, the PUM50 intrinsic subtyping may perhaps provide information that can be an ancillary information for decisions related to the use of neoadjuvant chemotherapy in patients with ER-positive, HER2-negative breast cancers. The third poster focuses on the prognostic and tamoxifen predictive effect of PUM50 subtyping and ROR score in the randomized SB2 trial. So the aims here of this study were to determine the long-term prognosis of PUM50 subtypes and ROR scores for premenopausal patients, and to define the prognostic impact of the disagreement between PUM50 subtyping and the intrinsic subtypes as defined by immunohistochemical surrogate markers using the St. criteria, and to determine the predictive effect of PUM50 subtyping for tamoxifen benefit. To do this, they used material from the SB2 pre-study, for which they had very extended follow-up with breast cancer free interval and overall survival of 28 and 33 years respectively. Surrogate subtyping was performed according to the St. Gallen criteria from 2013. And for the PUM50 subtyping and ROR, they used the nanostring platform. And here are the results for this analysis. We can see here on the top the breast cancer-free interval and the overall survival by PUM50, and as expected, in blue here, the luminal A tumors showing a much better outcome than the patients classified as other subtype. Now, the most interesting finding on this panel is when they analyzed breast cancer-free interval and overall survival according to the surrogate classifier for the intrinsic subtypes and the PUM50 classifier. The patients who were classified as luminal B by both the surrogate and PUM50 in red here had the worst outcome. That's fine. The patients classified as luminal A by both in green here had a good outcome. But importantly, the cases that were classified as luminal B by the immunohistochemical St. Gallen classifier, but luminal A by PUM50 in blue, had a curve similar to those patients who had luminal A tumors. The other important point is that for the ROR, the PUM50 ROR, we observe exactly what we would expect, that high versus low had a different impact on breast cancer-free interval and overall survival. Now, for the analysis of the potential predictive power for patients treated with tamoxifen, they observed something really interesting. When they stratified patients into luminal A or luminal B by PUM50, they observed that patients who were luminal A and received tamoxifen had a much better outcome than those who were controls. Now, that was not the case for patients with luminal B cancers, suggesting here that there is an interaction between the intrinsic subtype and tamoxifen response with an interaction p-value that was statistically significant. So in conclusion, in this unplanned analysis of the trial, the investigators observed that PUM50 subtypes and ROR scores were prognostic in premenopausal women. They confirmed previous observations that the agreement between luminal intrinsic subtyping by the surrogate classifier or by PUM50 itself is only modest, and that luminal PUM50 subtyping may have a possible role as a tamoxifen response predictor, but further analyses are required. Now, the fourth poster today is on the evaluation of the SABCS index and the 21 gene breast recurrence score in postmenopausal breast cancer patients included in the SWOG S8814 trial. And the SABCS index is slightly different from the first generation prognostic signatures in that it's a measure of transcription related to both estrogen and progesterone receptors, coupled with a baseline prognostic index based on anatomic parameters and also the expression of 4 genes: ESR1, PGR, ERB2, and Aurora kinase A. So what the investigators did was to apply this SABCS index to material from patients included in the SWOG 8814 trial that compared CAF chemotherapy followed by 5 years of tamoxifen with tamoxifen alone. And the goal here was to evaluate the SABCS index of sensitivity to endocrine therapy for the prediction of CAF chemotherapy and for prognostic performance in the context of the 21 recurrence score. The 21 recurrence score had already been performed in this sample, so they could do a comparison, an integrated comparison. So the results were as expected, that patients with a high SABCS index had a much better outcome than patients who had a SABCS index that was low. And this was in the entire population of this SWOG trial, and also when patients were stratified according to the therapeutic arm. On the left, patients who received endocrine therapy alone, on the right, chemo followed by endocrine therapy. Importantly, a multivariable survival analysis revealed that not only the SAT index was an independent prognostic marker, but so was Oncotype DX. Hence, they combined the two signatures and then asked, how do the outcomes of these patients look? And they observed that patients with a SAT index high, Oncotype low, had an excellent outcome, the blue curves, whereas in the yellow curves you can see the patients who were SAT index low, Oncotype high. And the patients who had a mixture of the two signatures actually had an intermediary outcome. The conclusions of this study were, first, that the SAT index did not predict benefit from CAF chemotherapy in this SWOG trial, that the SAT index and the recurrence score provided complementary prognostic information, and that the SAT index was prognostic in each treatment arm within the first 5 years of follow-up, but not after 5 years. And that each component of the SAT index provided prognostic information that was complementary to the recurrence score. I could not show it here in this presentation, but it is in the poster. And this actually brings us to the topic of the discussion of the next poster, that is that perhaps we need to combine different components of a signature or different signatures that leverage different biological phenomena for us to be able to predict the late relapses more accurately. And in this poster, actually, the investigators looked into the different components of the breast cancer index, the molecular grade index, and the HOXB13-IL-17BR or HI ratio to investigate the biology behind late relapses. And here the principles are the following, that early stage breast cancer patients have a good overall outcome. However, a significant subset of these patients will relapse, that breast cancers that recur early seem to be more active in terms of proliferation, whereas those that recur late may have a different biology and different characteristics, that most of the gene expression assays that are used currently to define which patients should receive chemotherapy derive their information from the expression levels of proliferation-related genes, and that currently we do not have a proper or a validated biomarker to define which patients would benefit from extended endocrine therapy after 5 years of endocrine therapy. And the author's hypothesis here is that the late relapses would have a complex biology that would be multifactorial. To address this, they used the different components of the breast cancer index and it has two components: the molecular grade index, or MGI, that relates to the expression levels of proliferation-related genes, and the HI ratio that relates to estrogen receptor-related genes. And they performed this analysis using the BCI clinical database for correlative studies. They included 7,477 patients. This database contains over 50 different clinical pathologic parameters and also genomic and genetic markers. And so the results are summarized on the slide, where cases were stratified according to histologic grade 1, 2, and 3 in the columns here. And then within each one of the grades, we have the molecular grade index in the columns and the HI ratios in the rows. And I hope you can appreciate here that there was a strong correlation between grade and molecular grade index. For instance, in grade 1 tumors, 64% of the tumors were molecular grade index low, whereas in grade 3 tumors, only 10% were classified as molecular grade index low. Now, for the HI ratios, there was a lot of discrepancies between grade and the HI ratios. For instance, only 30% of grade 1 tumors had an HI ratio that was high, whereas only 36% of grade 3 tumors had an HI ratio that was low. The authors next investigated in node-negative, ER-positive early-stage breast cancer patients how MGI and HI indices were distributed in patients classified by the breast cancer index as having a low risk of late relapse on the left or a high risk of late distant relapse. And what they observed was that for each one of these groups, the low risk or the high risk, there was a combination of MGI low-high and HI ratios low-high, suggesting that from a biological standpoint, the risk of late recurrence seems not to be exclusively associated with proliferation or endocrine signaling alone. It's a combination. So the conclusions of this excellent study were that first, proliferation and endocrine signaling are both associated with the risk of late distant relapses in patients with hormone receptor positive breast cancers. And second, and perhaps most importantly, that a combinatory approach leveraging information from the expression levels of proliferation-related genes with those related to endocrine signaling may reveal additional unique insights about the biology of breast cancers. And I would contend that a take-home message of this whole spotlight presentation is that perhaps for us to understand these complex clinical phenotypes and to be able to make predictions about the behavior of breast cancers at later time points, we'll need to leverage different signatures or signatures that leverage different biological phenomena. With that, I would like to thank you for your attention. I would happily take questions and also to discuss these posters with the presenters. Thank you.